first partner today, Gotsch. Thank you all for coming. Real quickly, how many entrepreneurs are in the room? Okay, and how many of you were in healthcare 5 to 6 years ago? No, of the entrepreneurs. Okay, most of you are new. And how many people from the healthcare sector, providers, etc.? Okay, all right. So until 5 years ago, health IT and votes had a lot in common. There were good ways to lose money. And so only in the last 5 years has health IT sort of become an area where when you go to venture capitalists, they don't look at you with cross-eyed and say, thanks very much, I'll be on my way. 3 things happened, if you want to bring it to a macro level. And I'm going to go through this pretty quickly just for the context of the panel. The first is $88 billion came from the federal government to help digitize electronic health records, so now you've got information that is digitally available. The federal government shifted financial risks to hospitals, and New York State shifted financial risks to hospitals by moving 5 million Medicaid patients from fee-for-service to managed care. So what happened was, and Maureen may address some of this, the hospitals went, holy crap, right? All of a sudden there was a need for new technologies to deal with the new data and the new financial risk. And the big providers, so the IBMs, the Epics, were all involved in getting that $88 billion spent for their bottom line. And not enough people were paying attention from the big companies to interesting innovations that would help the hospitals deal with these new issues that all of a sudden got thrown on them by the federal government and state government. So hence, we have a big renaissance in health IT. We put together the Digital Health Accelerator to address this. We pulled together 20 providers in New York State who all had a common set of problems. We brought some investors to the table. We partnered with an eHealth collaborative, which is building this platform which you've heard about. And the goal was to create jobs in New York, help bring a more robust health IT sector by helping early stage companies like Joe connect with providers who needed solutions like Maureen. So that's the context for our panel. We're going to now give you some individual perspectives about why there is, from a VC, a provider perspective, a lot of interest in the space, and then we're going to hear from an entrepreneur about what happened to him and some advice for entrepreneurs, and then Dave will talk about how do you, as an entrepreneur, get connected to all this digital information in a more seamless way than you having to hump around and talk to every provider in the state. So, I'm going to start with Maureen, and I'm going to sit down. So Maureen, let's start with, from your perspective, what's your biggest 2-3 challenges?
Okay. So I did get to see this question beforehand, thank goodness, because there's more than just 2 or 3 challenges that are facing us right now. Can everybody hear? Can you hear me now? Okay, good. So, like Maria had said, being in healthcare today is very different than 10 years ago. Over the last, I would say, 3 to 4 years, CMS, Center for Medicare and Medicaid Services, which is the government, has really surprised us very, very much in regard to the takebacks in order to address the overwhelming cost of healthcare within the, So, not only are we, can you hear me? Oh. Yeah. Thank you. So, not only are we dealing with reduced reimbursements that are happening across all of our insurance companies, but also we have the different programs that are happening coming out of the government today, reducing the amount of money that we're getting even from our government payers, Medicaid as well as Medicare. To put it in perspective, Winthrop-University Hospital, where I'm the Senior Vice President of Patient Care Services and the CMIO, over the last 3 years, we've had to pay back almost $20 million in reimbursement that we had received for patients that we felt required the care that we provided in the hospital, but the government decided 4 years later that it no longer warranted it. So we had to give it back. That was dollars that we did not expect to lose. These were dollars that we were budgeting for. At the same time, there's tremendous quality and value-based demands coming from not only our government payers, but also our commercial payers in regard to showing that the care that we're providing our patients have value. What that means is there's quality of care, which they look at our outcomes, but also certain measurements that they know are connected with either increased cost if we don't comply with that, or bad outcomes. Unfortunately, one of the challenges, though, is that they're using claims data as a surrogate for quality of clinical data. So, as a provider, as well as a hospital administrator, I see the flaws in that system. Claims data, first of all, is not really reflecting the story of that patient, truly, of what we provided for that patient every single moment while we're caring for them. But also, it's a different language. It's not really a true indicator of what we've done for that patient. So we're at a point now where we're being judged as healthcare providers, hospitals as well as doctors, by the government saying, you're not meeting the measures because of what we see in your claims data, and therefore we're going to ding you even more reimbursement penalties. In the meantime, we know we need solutions because although we see the word innovation here, and we all know in this room that we need to move towards using technology in a meaningful way to care for our patients and make our workflows more efficient, the people that we're expecting to use it don't want to change. They are very comfortable in what they're doing. They're very hard-headed in regard to what they're doing, and change is a very bad word for them. So not only are we expecting them to do more with less resources, we're expecting them to use tools that they feel very intimidated by, but yet we know they have to do that, and we have to change and turn their world upside down while taking care of another human life. Also being in New York State, it's a high litigious area. So we tend to have a very high awareness of malpractice. So the physicians, the nursing staff, the professionals all throw that card on the table. Well, are you going to pay, the suit when I'm sued when something goes wrong with this system, or I can't get to this patient because the system isn't giving me what I need in order to be efficient because it takes too much time? So, it's a very, very complex environment right now to really push change, push new technologies with less resources, less dollars to pay for it, as well as a user group that's resistant. We've been very, very fortunate at Winthrop that we sort of saw this coming way before the madness began, when the government decided to give incentives for people to adopt electronic medical records and other technologies. So we had some time to sort of slowly, fertilize the ground at the hospital and in the practices to get them used to using this technology. I really do feel for a lot of the organizations and systems that really have their feet to the fire, and they're going from paper to electronic overnight. And I'm telling you, it's not safe. We see that even putting technology in place without really thinking about how it affects process can affect patient safety as much as not having that technology. So we have to be aware of that. So I think those are some of the challenges that we're facing right now. And I know that, as fast as the technology is changing, our people are not. So, we have to sort of find, either they have to age out, or we have to find that user interface that is meaningful and easy and doesn't replace critical thinking. Because that's the part that I'm seeing is the danger zone. We can't have the computerized system thinking for the provider. It has to provide just enough information to stimulate that critical thinking. If it replaces the provider's thoughts, that's when we're going to screw up. And I've seen it actually happen when we've designed certain clinical decision support tools that they just, because the computer told us to do it, it must be right there. So we have to find that balance.
Okay, Todd, I hope you didn't have too much beer because I'm going to ask you a question not on the paper.
Okay.
So given all these problems that Maureen talked about, how do you as an investor sort of pick through which entrepreneurs to back. Like, what are you looking for in an entrepreneur? Because it's a very long list, and a normal, you might sort of reel back and say, forget it. And you hear the word litigation, right? Which is a lot. Yeah. So how do you sort of, as an investor, pick through all that?
All right, well, since we have an entrepreneur right to my left that we chose to back, Joe Mayer of CUREATR. We have good sound here. I can give you some insight into that. Let me just give you a brief overview of our fund. Milestone Venture Partners is based in Midtown Manhattan. We invest in early stage software and data businesses, largely in the healthcare sector, although we do invest outside the healthcare sector. And within the healthcare sector, we're backing early stage companies that are solving problems for pharma, payers, providers, and patients. And we've been doing it, quibble for a second with you, Maria. We've been doing it successfully since 2002. We don't think that 2007 was necessarily a watershed. There were great businesses to back and finance as far back as 2002. We backed a great one right in the heart of New York City, Metadata Solutions, which was a company that was helping pharmaceutical companies automate clinical development. It had about $1 million in revenue. It's public now, has many hundreds of employees in New York City, has $300 million in revenue. And so it's been a fabulous space for us. How do we figure out which companies to back? And for exceptional teams, people that are talented. In the case of Joe, he's a clinician, but he's also a great thought leader, and he's a great salesman. Let's face it, the guy works well with customers. But that's not enough. You also need a business model that makes sense. You've got to have a company that's going to generate recurring revenue, high margin, high gross margins, hopefully is helping move data around and helping solve workflow problems effectively. But that's not enough. You also need, in our case, a little bit of traction. And he had that. He had closed some business. He has some nice customers, and we were able to call those customers up, and those customers could say, gosh, this stuff is really good, and we're going to buy more of it, we're going to tell our friends about it. So having those ingredients really matter. And then we try to look for themes that we can get behind. There needs to be a thesis that we believe is exciting and big. And in the case of Joe, improving how providers communicate, I think is important. Automating workflow, I think, is a really important area for providers. So it's a mixture of things. I don't know if that helps or not. We're also looking for companies that don't need too much capital. Since we're a small fund, we don't want companies that need hundreds of millions of dollars to succeed. We're looking for companies that offer a relatively modest amount of capital, can proliferate their solution across a bunch of customers.
Okay. Oh, that technology.
Okay, Joe. So you are one of our poster childs at the accelerator. You got betas that convert into customers, you raise some funding, and you're creating employees here in New York City. So what's the secret? Like, what advice would you give to entrepreneurs in the room as to how do you get a provider to pay attention to you? How do you get them to spend time with you? How do you get them to beta test? And then how do you get them to sign and send you a purchase order, which means revenues?
I live across the room here. I see to answer that question, a lot of faces I recognize from providers who I went to, who said no to me. If I went to again, said no to me again. One right here, Dr. Davidson. I'm still working on it. But the short answer, I think, is persistence is obviously a key ingredient. Something called delusional persistence. I was very much all in on this, as Todd knows, as you guys know. I left my residency. I was a resident at Mount Sinai when I was doing this, and kind of convinced myself that this was the same thing to do, and the accelerator was a big help in that, just kind of having the validation of those kind of 20 leading payer provider awards who we pitched, who looked at our business. But I think a couple key things, on the more practical side of things, this is something I didn't understand at all as a clinician, but I learned a little bit about it on the research side, and then kind of a lot about during the accelerator. And Maureen kind of brought up a lot of good points about changes in reimbursement, very thin margins in hospitals. So we're pretty religious about everything we do. We must have a clinical ROI and a financial ROI that we can articulate to the customer, even if we're kind of, in some cases, faking it till we actually make it or can show it, which frankly with any early stage company, until you get the volume of data is the case. And then I think the big thing, and Todd will tell you this, we were fanatical about going out and selling, even when we had a very basic product, as opposed to kind of staying home and trying to build more and trying to kind of figure out how to build the perfect product. So we sold things we probably shouldn't have sold, and then figured out how to make them work because we had customers who really kind of believed in what we were doing and were willing to work with us until we got it to work. So.
And a leading question. How hard or expensive is it for a provider to test your technology?
It's gotten more expensive since we raised money from Todd.
Too big a test.
Yeah, we no, but we're cloud-based. Very kind of cloud-based, mobile first. All of the things you kind of hear about and read about. The kind of leader, the groundbreaker in this area were companies like eHealth and many data. And to take a page out of their playbook, we can go in and we can deploy kind of a basic version of our product at very little cost to the customer dollar-wise, but even more importantly, very little work for IT. And I think that's actually what's the most important. It's not just about the dollar amount, but it's internal FTE resources, and IT's job is to say no. So clinicians always say yes to us. IT always says no. So that's kind of how we've designed our go-to-market to deal with that.
I could add to that as well. Being in the first mentorship round with New York Digital Accelerator Program, one of the things that I found just so enlightening and so refreshing was the way the program was designed, that the mentors, the hospital and the provider mentors, actually got to work directly with the startups that were selected. And it was such a, just such a refreshing change in the way the typical vendor relationship was, from my perspective, where they were just pushing the product that they built and not necessarily listening to what our needs were. And the Digital Accelerator really did, open up that conversation, and it was an agreement right from the beginning that we were going to work together. And in regard to cost, to me it was invaluable, the use of my resources in the organization to truly work with fresh, open minds, saying, I want you to make my product better, and I want to be able to deliver something that's going to be marketable to healthcare space, not just the same old thing that we are seeing that is a round peg in a square hole, like, oh yeah, we can make that work this way, and it doesn't really meet the needs of what we're looking for. So that investment of time and resources, like Joe had said, was just so invaluable, and we still are working with two of those companies that we were paired up with, developing that product and really seeing how it can work in that healthcare space that's more meaningful for us, instead of just another widget or another niche product that will only handle maybe one little piece. We've made it grow and actually see synergies between different companies that we've been working with on how we can make something even better.
It was a similar story to that. We went in, we got matched with three provider organizations in the accelerator. Two of them we sold sort of our original product to. The third one, we're now almost a year later launching a very exciting pilot with, they went out. This is a pilot that is for inter-organizational and inter-organizational use case. They went out, they recruited 4 other provider organizations, and we built basically an MVP of this kind of new product module with a lot of input from them. No dollars have changed hands, but it's been a very, very valuable process, and we're about to launch this pilot, and Todd and everybody on our team is very excited about it, and that's not something that you often have the opportunity to do.
So now we'll turn to Dave. Since we're on the theme of helping entrepreneurs, why don't we just tell the group what is The Shiny? It's not a movie, it does not involve Jeff Nicholson. What is it? And what do entrepreneurs need to know about it? How is it helpful to them? Why should they care?
Okay. Can you hear me okay on this? All right, we'll work with this. You all know that the federal government has made a major push in the last years to get doctors and hospitals to automate, right? So the typical scene in a physician's office is all those paper charts. And God help you if you need to move any part of that paper chart to another doctor, you know what you go through between faxes and copying and everything. It's a nightmare. So the federal government said, okay, we're going to put money on the table to automate, to incent physicians and hospitals to automate. And the adoption has been wonderful. It's really moving along extremely well across the country. But here's where New York is special. New York said, not only are we behind that, but we want to make sure that if you think of the state of New York and you think of each EMR that's out there as a point of light, when you darken the room and you see all these thousands of points of light, well, we want those points of light to merge. So that, just to take two simple examples, somebody lives in Queens and was referred to go to a specialist in Manhattan, guess where their records are? Back in Queens. And they have to go through all that pain of having those records printed out and take along to the specialist in Manhattan. Another case, somebody is somewhere else in the state and they have an accident, they're in the emergency department. They may or may not be conscious. They may not be able to answer questions about their allergies, medications, other conditions, and that's extremely critical information. And a lot of time is wasted as contrasted by if you had access to that information, trying to do tests over and trying to reach people and so on. Those are just two simple of hundreds of use cases that justify to the state government of New York that it's worth making a big investment to create health information exchange. And this resulted in investments of close to $1 billion, that's with a B, not an M, since 2006, which has created 10 different health information exchanges in the state of New York. In the New York metropolitan area, the rest in the upstate area. That's cool, but what happens if somebody's records are needed across those areas? And that's where we come in. Our organization was chartered to create an umbrella network across the entire state of New York. So no matter where someone needs care, their entire health record is available to be seen. And that's a huge potential benefit for entrepreneurs, for a simple reason. If Joe or anybody else has an app, and they want to deploy it on a pilot basis or even further with a particular hospital, they have to interface to the data in the EMR. They have to interface to the EMR with the specific interface specifications of that EMR. You know that there are hundreds of EMR companies out there now. Some are more popular, but there's many, many others. Interfacing to each individual EMR is extremely costly, extremely time-consuming, extremely error-prone. The Shiny, which is the umbrella network across the whole state of New York, has the ability to enable Joe or any other entrepreneur to interface once in a standard way to get the data out in what's called a CCD, which is a standard document for a healthcare record. That's huge by itself, and that's going to enable, that's going to disturb and perturb and disrupt the ecosystem in New York like nothing else. And one last point, New York, make no bones about it, is leading the country. We go to conferences all across the country. Everybody's saying to us, how are you doing this? Can we copy you? Can we get on board with you? So you have a lot to be proud of.
Okay, now we're moving into the lightning round, all right? So the answers to the questions need to be short and crisp because we've all had some beer and the food's on its way. And we're getting here to the end of our panel. So, Dave, what is the cost for an entrepreneur to connect to the Shiny? How much money does it cost them?
At current, nothing.
Free. It saves you time and money and it's free. Okay, Maureen, name two problems you have, which you'd like a solution from an IT perspective.
Communication. Go, Joe. Patient itinerary. I know it sounds crazy, but Microsoft Outlook for patients. You would think that a central scheduling solution should do that, but it does not. And I know I'm working with some startups already to try to find that type of solution, but they're struggling with it. So that's definitely the secure communication and a patient itinerary.
I'm gonna give Maureen.
I actually planned on talking to you today.
All right, accelerator input. All right, Joe, what are you looking for in terms of resources, hiring, not existentially in life, but for your company right now today?
Yeah, I think for us, what's been great, tied back to the accelerator, is just telling the world about what's going on kind of in healthcare IT right now, and kind of in terms that everybody really understands. I mean, I talk to folks I went to medical school with, they're residents, fellows, and physicians, and they haven't really heard of accountable care, and they don't understand what's coming, and they don't understand the changes that are happening. So I think, the more that everybody here on this panel and here can kind of just get the word out and really just, this is a critical time in the healthcare kind of ecosystem. So I think, what you guys are doing is great for kind of getting the word out there, but we need more of that. So the provider works too. Still, the bulk of the revenue is still fee for service, and many of them are not yet paid. So.
Okay, Todd.
Yes.
What is your favorite investment theme today?
Favorite investment theme today is helping constituents in the healthcare ecosystem better manage risk. So plans are having to assume more risk, providers are having to assume more risk, and consumers, all of us, are having to assume more risk. Software companies, data businesses, cloud, analytics, mobile companies that help those customers manage that risk better is an area where we are putting money into.
Okay, now we're going to move the last set of 4 questions, which is the land of shameless self-promotion. And then we'll get to your question. Okay. Start with Todd. Why should people apply? This is a question for the first 3, for Todd, Joe, and Maureen. Why should technology entrepreneurs apply to the Digital Health Accelerator?
Because you can get customers and you can form relationships with knowledgeable providers and you can get closer to venture capitalists because the program has both of those things.
Joe?
Again, just to say that we got 3 customers, 1 venture cap, 2 investors, and a lot of great press and a lot of great exposure. So it's, I think, unmatched when you look at kind of other opportunities out there to get all of that from one organization.
You get inside the doors of the organizations and your future customer, and you get to hear what we really need from you and develop those relationships. You can't build a product without listening to what the needs are of your customer, and we give you that as part of the Digital Accelerator. And we really look at it as a partnership. So, because we're all going to win at the end if something comes out of this that's usable and successful. So, and it's one of a kind with mentorship.
And David, what date are applications due and what is the website?
Say it one more time.
What date are applications due and what website should people go to?
Oh, a specific question. Okay. So the applications can be filled out as we speak. It was announced a few weeks ago. They're due April 11th, probably. With probably not more than 6 or 7 extensions. No, really, April 11th is when they're due. And the evaluation period will take us to early July. And in early July, we'll kick off the class.
Website is digitalhealthaccelerator.com. Okay, we're done. Questions? We have questions? Scott, questions?
I can take one of the mics and do the questions. I always try to be the Van Wyck figure in the evening. It's important to me. Yes, Raymond. How you got that?
Tomorrow, at some point, one of the largest databases of pricing for hospitals will be released from a U.S. domestic standpoint. Do you guys have any idea of how, looking at capitalizing on the idea of the discrepancy of a knee surgery that could be $6,800 in Akron, Ohio, or $85,000 in Midtown Manhattan works, and how do we get ahead of that and look at that as a whole from that new data set that tomorrow will be an absolute virgin place to look at applications?
Well, that area of price transparency is a huge area. One of our portfolio companies is here tonight, Vitals.com, which provides transparency solutions to health plans and self-insured employers. And a company, Past Life Health, as you may know, just went public. $11 million in revenue last year, maybe 30 this year, worth $2.5 billion, give or take. Basically on the premise that that's a $5 billion market opportunity, and you know, helping consumers make more intelligent decisions about where to get their health care at a better cost, higher quality, is really the sweet spot of health IT right today.
So from a hospital administrator perspective, I think the full transparency is wonderful, but until we get to the insurance companies and the contracts that have been established between the payers and the providers, you're going to see variation. And as Todd had talked about, with taking on more risk with the accountable care organizations and the ACA, which I can tell you that our organization is not jumping on that bandwagon very quickly. We're just going to ride out the fee-for-service train as long as possible, because that's where we're getting our reimbursement. And to take on risk at this point, it's really we're not sure if that's really the way this is all going to be played out. You're going to continue to see variation regionally and based on payer. And I think having this transparency is going to raise very good dialogue with the consumer. But I don't know if it's going to satisfy getting everybody in an even playing field.
So it's true that, just as I said, 8,600 to 85,000, the insurance payout is a $200 difference. It's
Correct.
3,300, 3,500.
Correct.
Same space as whole, and that's your business, right?
Depending on the payer.
Correct.
Because there's some that are percentage of charge and some that are just fixed rates.
And how do you feel about that as an administrator, being that crazy amount of profit margin, or not?
It's crazy. It's very hard to predict what our income is going to be, because our payer mix could very well change. It's a challenging...
Beyond business, emotion, how do you feel about that? That's amazing. That's not business. That is a huge...
It's ridiculous.
Discrepancy. It's ridiculous.
It's ridiculous. It's ridiculous. However, hospitals will not be able to keep their doors open if we even the playing field.
How can we find new business models for you?
And reimbursement continues to drop from our government payers.
No, my question is, how can we help you by finding new business models?
Right.
So we're going to...
You can.
One more question. We have two more questions tonight. Two more questions.
This is for Maureen. What practical advice do you have to entrepreneurs from an IT perspective? To Joe's point, their job is to say no. How do you get them to say yes to your solution?
You mean how to get IT to say yes? IT has to believe that it's what the users want. Okay? And many times the users don't know what they want. IT historically was the department that would bring these solutions to the user, but that's changing now with the role of the Chief Medical Information Officer like myself, clinical informatics departments in organizations where there are end user clinicians that are IT knowledgeable, but not necessarily IT people. We're the ones now, we're the group that vendors should be going to. The ones that are going to understand the link between the technology and the actual clinical workflow and the value it will bring to the clinician. I think that most of the organizations are we're evolving, those IT departments are evolving now to be sort of a blend of technical and clinical informatics, which I think is going to take some time because we still have some, that legacy, old, stodgy, I'm a mainframe operator and I just take care of the infrastructure. And, instead of really looking at the big picture. And I think that's what I'm hoping we're going to see over the next 3 to 5 years, because nothing happens fast except for technology advancement, that we'll get to that point where there's a full understanding of who the vendor should be going to.
All right, I promised one last quick question here. We're going to have to be kind of quick on.
Okay. Hi, I'm Swarna. I'm the founder of a company that's developing asthma management software. New way to self-manage asthma. And like many entrepreneurs in this room, my target audience would be hospitals. And this is probably the big question in the room, and it's targeted towards Maureen, Joe, and Todd. You've all given different aspects to this question, which is that we all are in this business to make an impact on people's lives, but in a commercially viable way. However, we know that hospitals have your financial challenges. We know VCs have their requirements to show traction. So what if any, advice do you have to give us to try and come up with the right innovation in the quickest possible way to get to a commercially viable business model?
Quick responses, because I hear bellies grumbling.
I think the problem that we're going to be facing is that there's so many niche products out there, and hospitals are not going to be able to continue to afford to pay for them. We have to find some common platform for application interfaces, and I think David alluded to that with the Shiny, that if there's some place where we can plug in these applications and the hospitals only have to pay for the platform, I think that would make it much more viable and a sustainable model for us, because having all of these different, compliance enhancers, data, business analytics tools, communication tools, we're going to go broke. And what's going to happen is we're sitting on a software bubble, so to speak. So I think that's my dream, is that we would have some type of player for all of the apps.
I would recommend that you apply to the accelerator.
Thank you.
The other, our biggest customers are not hospitals. They're big services providers that take risk, that are run by, companies that are run by former Bain, Booz Allen, McKinsey guys, and often, you can work with them, figure out the business model, and then go back to the hospitals, because to Maureen's point, the margins in hospitals are very tight, but these guys are for-profit, operate differently.
Okay, oops.
I got Maureen.
All right, I'm hungry, so we're going to stop.